what I'm going to do is that's all I'm going to say about the scene. I think you're probably aware of it far more than me, but I will kind of dive straight into the demo. So if you're not familiar in primary care, there's obviously huge amounts of frameworks. So it's not just QoF, it's IAF, it's CQC frameworks, it's diabetes care processes, NHS health checks. Southwest London has got its own, obviously, ICB framework. So there's quite a lot for primary care to deliver amongst all the other things. But the good news is that this part is much more automatable in a safe way than reactive care, where we often end up, and demand, where we often end up focusing. So this is what the product looks like. We'll start with the population view. So what we've been able to do is to integrate with EMIS and System 1, and we are able to access all of the data on a daily basis and run every single search on all the patients in your population. So every morning, all the searches have automatically been run without doing anything by any member of staff, without slowing down EMIS, which happens a lot if you use that system. So here we are. Here's all my population, and anything that they need is being shown here. And if I wanted to look for a specific subpopulation, so I always use this example. So anybody on DMARDs, in one click, that's the population that I want to look at. Or if I wanted to construct that myself, I could say, okay, methotrexate, these are the high-risk drugs, azathioprine. And you can see that I've been able to run that search in 1 second rather than many, many hours, which is what it would have done for EMIS to find those patients. And I can do lots of granularity there. I can exclude the patients that are housebound. I can exclude the patients who are on the palliative care register. And it works very, very quickly. And once I then want to action this, I want to bring these people in, I can select all and send them a message. So now the first bit is what you probably use a system like Ardens or PCIT for if you're not already using Abtrace. There are about at least 20 practices in SWL that are already using Abtrace, with about 10 more coming on at the moment. But if you're not using Abtrace, then you would have run that search. It would have taken you a few hours to find that population. Then you would have downloaded it and uploaded that into AccuRx, and it would have sent an email or SMS to those patients. We do all of the same functionality, but now it's taken a few clicks to find the patients, and then you can directly send messages or emails, and soon you'll be able to send an NHS app message as well via Abtrace. So you can contact that patient very quickly. Unlike AccuRx, we will not charge you for fragments. So there's no additional charge for messaging. It's all built into the cost. And the reason we're able to absorb that is that we are trying to make you send fewer messages, not as many messages as possible to your population, who also probably want fewer messages. So it does all the things you'd expect. It sends messages. You can specify specific codes to be added into the record. Everything gets written back into EMIS. You can specify specific staff members or specific clinic slots and the time in which you send that appointment. So you can very quickly identify the population and contact them. But rather than doing this over and over again, and for this population, for example, for the methotrexate patients, these people need to come in 3 times or 4 times a year, every 3 months. So I don't want, even though this is taken from 20 minutes to 1 minute to do, I still don't want to have to do this every 3 months. So what I'm going to do is set up an automation, and now the same population is going to be automatically recalled. In fact, what I might say is, for this high-risk population, I actually want to bring them in before they become overdue. So let's bring them in 2 weeks before and then set up the automation. So now these patients are going to be identified 2 weeks before, automatically messaged. And you might say, well, in some cases, I want to set an upper limit. I only want to maximally bring 30 people at a time per week. And so this is going to identify the top 30 people. You can prioritize them by the most overdue patients, or you can use a risk stratification framework. So if you're using Johns Hopkins or you're using UCLP framework or any other target-based risk stratification that you want, you can bring these people in that order, and that's already built in. And again, you'll know that this year there's some payment towards using risk stratification, but the idea is that this is just inbuilt. You decide which population you're going to bring in, when you're going to bring them in, how many you're going to bring in, and what order, and this will run it for you. So it will automatically identify and bring in all the right people at the right time. It's quite clever. So and it's very dynamic. So rather than having a fixed date, so I have my blood test now, so you schedule me in for 3 months' time. Actually, it's going to reevaluate me every day. And if I stop being on the drug, it'll skip me. Or if I happen to have that blood test for another reason, it will skip me. If I book in an appointment for another reason, it will skip me. And it will also contact me as many times as the practice wants. So if you were doing your flu, smear, NHS health check recalls, the kind of business rules require 3 messages to be sent a month apart. So you can schedule that in. Okay, I want 3 messages to be sent and I want them 30 days apart. And actually, if they book in with my nurse, these are my 2 nurses, and they book an appointment, then I don't want to message them because that's probably for the smear. But if they book in with my GP, they're not going to get their smear done, so I still want them messaged. So it's very clever. It works it out. It does exactly what you'd expect a member of staff to do. So the point of all of this is that you will usually have someone spending 5 working days, so pretty much their whole week, or maybe split across a group of staff members who are constantly doing this. They're running searches, identifying populations, and sending them recall messages. Now that's dropped down for 2 hours a week because all you're doing is making sure there's enough appointments, or you're just focusing on that population that you've messaged 3 times as you've been required to do, and they've not booked in. So your human staff are spending time on focusing on the patients with inequalities, the patients that have challenging access, rather than kind of constantly repeating the same repetitive task over and over again. The routine patients, they come in themselves, and we give you total control. So every patient that is messaged, you'll get a kind of audit trail. You'll be able to see who we've messaged, who we've been able to unsuccessfully message, and it will give you all of that. And we'll also show you where people are on that recall. So this is a smear recall. You've asked us to message them 3 times. So 42 we haven't started yet because you've set a limit. 70 have had 1 recall, and then however many have had the 2nd and 3rd recall. And then you can just let the system work that out. You would only focus on the patients that we've not been able to message because we've tried and they've not responded, or they didn't have valid contact details. So human beings focus on that population. The vast majority get done automatically. So this is a population health automation that is not using bots. This is not RPA, which means that it is medically certified. It has all of the security certifications, and it uses APIs, and it doesn't break. So it runs itself, and you can hand over vast amounts of work to Abtrace in a way that you can still control. You still control how many patients are coming in, which of your recalls you're optimizing. Now, once that patient does come in, you don't want them to have half the test done and then walk out still overdue. So what we give you is a patient, whichever patient you have open in EMIS will also open an Abtrace, and you'll be able to see what that patient needs. So that nurse or HCA that's seeing the patient, or even the receptionist, can say, I know you need a few other things. I might be able to do some of those things myself. I might be able to give you a urine dip pot, for example. You might have come in for 1 blood test, but I can see that you need a few others. If I want to know the detail, it tells me why I need these blood tests, because often there's multiple indication, multiple rule sets. And it also looks ahead. So it says you don't need your blood pressure today, which is why this is not red, but you will need it soon. You might be 1 month away, or you might need it for the cough year. So you can be opportunistic and you can get that done and avoid bringing that patient back in again. And that's what this view is showing you. So the idea is that you very easily bring the right population through your doors, and remember that 1/4 of all appointments are to do with this sort of work. So you automate the kind of recall, and then you make sure that you make the best use of it. And when we look at the data now across the country, to start with, only 1/3 of appointments have everything done. So 2/3 of the patients, when they walk in, they have things that they're red for, they're overdue for. The HCA nurse doesn't realize that, and they walk out still being red for some of these things. And then they get brought back in again by maybe a different team, and they have to go through the same process. There's a few other things just to run through. We also have prevalence registers, so there's quite a lot of codes missing. We found 80,000 plus patients in the UK that have missed a chronic disease code. So this patient should be on the epilepsy register. They are epileptic. They have a letter talking about epilepsy, but it's not the right QOF code, so it doesn't appear in the searches. What you can do is you can click accept, select which of the specific codes you want to choose, and backcode that back in. And an average practice will find at least 1,000 patients that they've incorrectly coded, and those patients might be missing out on the care. and the practice is probably missing out on the income that they should be getting. So this little module here alone usually for the first year ends up paying for 2/3 of the cost for an average practice, which is why a lot of your practices and PCNs have signed up even when they haven't had central funding. And I'll come back to that in a minute. A couple of other things to mention, particularly if you're wearing an ICB or a population place hat, we have inbuilt analytics. These are dashboards that don't require you to upload data or to run any search. They auto-populate. And what they're showing you is the same data. How are you doing against your foot checks? But the difference is that rather than showing you that there's a gap in what you should be providing, and we're telling you there's 1,000 patients overdue, in one click, you can actually see who those patients are. So it's not just a dashboard that tells you you're not doing good enough. It actually gives you a mechanism to do something about it. We take utilization very seriously, so we give you a live dashboard of which members of your team are using the product, and you'll be able to see that. And you'll also be able to see your performance as a practice and compare that to your performance at this time last year. And our team will sort of reach out, proactively monitor this for you and help do all the training and so on to make sure people are using the product. There's a couple of other bits of functionality which have just been launched. We've got questionnaires, so rather than just sending them recall messages, we can also just find that bit here. You can also send patients questionnaires, and that will allow the patient to be able to not just book an appointment, but also answer questions. So if you send them a blood pressure questionnaire, an asthma questionnaire, a lot of this work can be done without needing an appointment, and the patient just does that on their phone. The way this is different to the questionnaires you might already use is that we know everything a patient needs, so we can automatically make available to every patient the ability to answer everything they need to do, rather than you having to send them specific messages or to figure out what population needs to be sent what questionnaire. It is a unified questionnaire where anything a patient needs to do is made available to them. And then once that comes in, it gets coded back into the record. The final thing I will mention is that we've also built capacity planning dashboards, which essentially means that you will be able to see what your capacity looks like over the next year, what you need to do over that period of time, and how best to kind of move your demand around so that we know that summer is a quieter period. This is the time to bring certain people in, but you want to bring the right people in, not the people that you're going to bring back in the winter for flu anyway. And it will help you find that. And then you can also, at the time when it's busy with the flu season, etc., you can pause some routine activity and pick it up again. So the old rigid birth month recall system is not as efficient as what you can achieve with Abtrace, where each patient is being brought in based on their need, and we're taking into account all of their needs. The last thing I'll mention, I think I've kept to my 20 minutes, is the cost is 70p for a practice and 56p for a PCN, and then we do further discounts at a higher level. We've signed up quite a lot of practices within SWL. One of the things that's been very successful in other ICBs is a co-funding model, where rather than funding the bottom 10% of practices, the ICBs have offered the practices 50% kind of co-funding, as long as the practice puts in 50%. And the reason that's been very popular is that the practices then have skin in the game, and they've chosen to participate. They obviously get the benefit of that targeted support. And what we found in that ICB is that 10% of practices signed up, but within 3 months, 40% of the ICB signed up. The ICB didn't pay for the rest. The practices paid for themselves, but it created momentum. And then we were able to get the whole population to work together, share practice. We created seminars where all the different PMs, the practice managers, came and learned from each other. So that's been a really successful implementation, and I can share data about that or answer any of the questions that you might have.
Thank you. Well, that's really helpful and great to see. Just also wanted to mention that you're also working with GPIT in South West London to go through all the relevant compliance checks, that GPIT need to roll out a product in South West London. So we're on the road to getting it passed through. So opening up to questions.